Well, hello, everybody. Welcome. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And it's good to be here today. I wanted to welcome you all to today's live webinar. It is hosted by WellSky, and it is called VNS Health, leveraging real-time data to optimize placements, maximize reimbursements, and improve collaboration. So this is a good case study that I think you guys will really enjoy. And I got a chance to have a little bit of a preview. I think you'll really like this. Today is, by the way, Halloween, so happy Halloween as we are recording this to all of you out there. And hopefully the presentation today won't be too spooky. But a few items of note before we get started is everyone's joined today in listen-only mode, so you don't need to worry about muting your microphone or turning off your camera or anything. But we do want to hear from you, though. So we are going to have a time for Q&A towards the end of the presentation, at which we will answer as many questions as we can during the allotted time. If you have a question, you'd like to submit it, you don't have to wait until then in order to do it. Go ahead and use your control module there, and there's actually a place for questions. It's different than the chat, so make sure you put it in the right place. And we're going to get to as many as we can. If we don't get to yours for some reason, don't worry, someone will reach out via email afterwards and make sure that they answer your question for you. And then I'll remind you guys again how to ask the questions when we get to that point. But without further, and one last thing, we are recording the session today. So you'll receive an email from us afterwards, maybe about an hour or so after the presentation. There'll be a link to the presentation, and that link you can actually share with colleagues or friends, and you will review it again yourself. So it'll be a link to the recording and also where you can download the slides. So without further ado, wanted to briefly introduce our speakers today. We have Mr. Devin Woodley, and he is the VP of Managed Care Contracting at VNS Health. And we have Mr. Tom Martin, who's the Senior Director of Data Insights with WellSky. And I believe Tom is going to get us kicked off. So welcome, gentlemen.
Great, thanks, Garrett. Good afternoon, everyone, and thanks for joining us today. Happy Halloween. I'll admit I did consider wearing my costume as a gag to the session, but my wife talked me out of it. So Devin, WellSky marketing team, you can thank her later. Like Garrett said, I'm Tom Martin, the Director of Post-Acute Analytics here at WellSky, which means I'm in the very envious position of having access to one of the best real-time databases tracking patients in various value-based care arrangements across the care continuum. I've worked in the post-acute space for the last decade, and today I'll be sharing some of the insights we've derived from this really great data we have here at WellSky. And I'll start and I'll thank Devin for joining us today. I'm very fortunate to be joined by Devin as a fellow presenter. I think Devin is among one of the people I know with the most knowledge of how value-based care works, because he comes both from a payer background as well as a provider. So it's going to be great to hear some of your insights today, Devin, on the approach you guys have taken at VNS. The agenda for today, 3 different goals. The first is we're going to start off, and through some of the data we have here at WellSky, we're going to share with you some of the industry trends we have seen as it pertains to discharging patients from the acute setting and ensuring safe care transitions into the post-acute space. And then we are going to talk a little bit about some of the WellSky clients of the CarePort solutions and what are some of the strategies they've implemented most recently when it comes to building preferred provider networks of post-acute providers, as we see this continues to be, a really excellent strategy for, reducing costs and improving quality for value-based care populations. And then finally, I'm going to pass it over to Devin, and he can sort of, share the VNS approach, how they've showed value with real-time data for their referral partners, and then some of the programs, the clinical programs they've built at VNS to help drive value-based care. So a lot to cover today. Let's jump into it, and I'll start kicking it off with some of the industry challenges and trends. The next handful of slides I'm going to be sharing today are a little data heavy and dense. So I'll start, just describing at a high level what is the data source we're going to be looking at, and then I won't go into it in detail for each slide. Today, I'm going to be sharing with you primarily referral trends and the characteristics we've seen of patients as they move from acute to post-acute. One of the WellSky CarePort solutions are tools that discharge planners use to refer patients to the post-acute care space. And then we also have some solutions that the post-acute providers use to communicate back whether or not they can take those patients. I will primarily be discussing that data set today. We have today roughly 2,000 hospitals contributing data to us. And so while it is not a perfect representation of what all health systems across the US are doing, all 5,000 hospitals, it is a pretty large sample and definitely a population that tells us what's going on across the industry. So with that said, that's a little background information. Let's start jumping into some of this data. The first trend I want to share is that we continue to see a high demand for post-acute care services. And there was some lack of demand across some settings for certain levels of care in post-acute, but that demand has recovered. So what I'm sharing with you here is a chart that trends discharged inpatient stays that are referred to SNF and home health. SNF is the orange line and home health is that pink line, as a percentage of the average month in calendar year 2019. Okay, so another way to say that is I'm basically trending demand for these two level of care settings. When you see a number that is greater than 100%, that means that demand for that level of care was higher relative to what the world looked like pre-COVID calendar year 2019. And if you see a rate that's below 100%, that means demand for that level of care was below the average month in 2019. And so looking at this trend here, you'll see that across 2019, because that's what we made the baseline off of, there's a somewhat steady demand for both home health and SNF services. There's a little bit of seasonality here, but it hovers around 100%. And then in March and April of 2020, we see a huge plummeting of patients that are being referred to SNF and home health. This was obviously the time that COVID came about, and we saw that the type of patient, upstream in the acute care setting that required post-acute services was not going to the hospital. If you did not really require care during those months, you were not going to a hospital. Certainly there were no elective surgeries, so the patients that were needing skilled rehab in a post-acute care setting, they were not in the hospital to be referred to post-acute care. So we saw this huge dip. And then, sort of the first trend, what, maybe should not have, but did shock us at first, was that in later 2020 and early 2021, we saw a very rapid recovery in demand for home health services, right? And so in 2020 and 2021, we're at about 20%, 20% increase in the number of patients in the hospital that are being referred to a home health agency. So really, a significant increase. And this is over, millions of referrals we were looking at this data. And then we saw the SNF data sort of lag behind, where, across 2021, we really did not see demand for SNF services recover. And, I think at the time, as the CarePort analytics team, as we were looking at this data, we were very much gravitating towards the, I love this term, I did not coin it, but I'm a basketball fan, where they say like the jump ball patient. So the patient that was always at the acuity level where they could have succeeded at the home with services, if all the work was done and the coordination was put in place for that patient to succeed in the home. And so we kind of saw like those middle acuity patients, those jump ball patients, we thought they left the SNF setting and were now like permanently that level of acuity was going home with services. And that we did find that to be true. When we looked at acuity levels, we saw a more acute patient going to home health. And the few patients that were still going to SNF, they were at a higher acuity level as well. But I think what's really interesting about this data in 2023, and we're tracking this data up till September of 2023, we have seen for several months now, I mean almost 2 years, demand for SNF services has returned to what it was pre-pandemic, and we have not seen a decline in demand for home health services. And that's telling us that while the jump ball patient might now be going to the home instead of the SNF, the total pie of patients requiring post-acute services has grown over the last 3 years. And we have yet to see this sort of demand, diminish at all. This is almost like 2 straight years we've seen elevated demand. So trend one, the latest data we have here at WellSky, looks like very strong post-acute demand. Trend number 2, I will share with you, is that staffing challenges continue to be a significant issue in the post-acute care space. I'm sure we've all read about this or we've experienced it firsthand. What's interesting is my former life, I worked at the American Healthcare Association, the association that represents nursing homes. And I remember back in 2017, the #1 concern of nursing home administrators who were members of ACA was staffing, like retaining staffing talent. And then, of course, nationwide, there was a staffing crisis. And after 2020, coming out of COVID, we really saw this issue get elevated. And so what I'm sharing with you here today is what I think is probably the best indicator of the staffing crisis in post-acute care. And what I'm trending is data from the payroll-based journal. For those of you who aren't familiar with that data set, CMS mandates all 15,000 nursing homes across the nation periodically submit their staffing pattern. So like, what type of staff have they hired? When did they work? How many residents do they have, so they can calculate like hours per resident day. It's a really rich data source, and it's fairly current. And one of the metrics you can calculate from that data is the percentage of direct care staff in a nursing home that is filled by a contractor. Okay, this is a really interesting stat to trend because nursing homes, for the most part, are not going to be hiring contract staff if they can help it. This staff can cost up to 4 times what it would cost to employ a regular full-time employee, so considerably more expensive. And you can see, as we look at this for the average nursing home, going into 2020, almost 10%, a little north of 10% of the direct care staff were filled by one of these contract agency staffers. And so, nursing home would not be footing that bill if they were not really finding it difficult to hire staff. So definitely staffing continues to be a significant challenge. So we have not only do we have this demand surge, but at the same time, we sort of have a supply issue where it is difficult to hire staff in post-acute. I will say one silver lining, we are now 2 quarters of seeing the average nursing home reduce their contract agency usage. This might be a positive indication of things to come, but definitely still a significant problem. And I should have said this at the start. While this is just nursing home data, because this is the data that's available publicly, I mean, the pool of talent that a home health agency or an IRF might be competing for is similar. So this is probably a pretty good indication of what's happening across the post-acute care space. Third trend I'll share is that, and I'm sure we've been reading about this, I think the headline stat from CMS is this is the first year that Medicare Advantage became 51% of the Medicare beneficiary population. So 51% MA, 49% are now fee-for-service. We have also seen that trend in the patients being referred to post-acute care. We've slowly and gradually seen an increase in the penetration of MA. In 2023, it was the first time we saw that a Medicare Advantage patient being referred to home health was the most common patient being referred. And so we're lagging a little bit behind the average Medicare beneficiary population because MA penetration will be higher in younger populations. And as you look at your 70-year-olds and your 80-year-olds, MA penetration is lower. But among those patients that are starting to require post-acute services, we are seeing that increase. This is a telling trend. in that we know that an MA patient, the friction for a care transition is a little bit higher, right? There is this prior auth process, which will slow down the time it takes to get that patient to the next level of care. We know that the reimbursement rates for an MA patient can be significantly discounted from the fee-for-service population, which sort of lowers, we're seeing the incentive for the post-acute provider to quickly agree to take that patient when they might still get a fee-for-service patient. So this is providing some friction to that care transition process. So to recap, right, we're seeing high demand, low supply, growth of Medicare Advantage, which is making these care transitions more difficult. Because of all those things, it is creating a difficult environment, and it's more challenging than ever to transition those patients to post-acute care. We have seen the average number of referrals that are required for a discharge planner to send a patient and make sure they find that next level of care. The number of referrals they're sending has doubled. So you might be sending, 5 referrals for a patient going to home health last year, or in 2019. Now you've doubled that. Now you have to send 10, which is increasing the workload on discharge planners, increasing the workload on post-acute providers who are getting inundated with patients that they may or may not take, and it's just creating almost like worsens the cycle of staffing crisis because there's so much more material to review on whether or not you can take a patient. Ultimately, where this is creating a problem for the healthcare system is in hospital average length of stay, right? And I think these are I know I'm sharing a ton of data with everyone, but I think these are probably the most staggering statistics, is that when we compare the average hospital length of stay to a SNF in 2019 to what it was in calendar year 2022, is 12% longer. This is over millions of patients. We're seeing about a 12% increase in how long a patient is in the hospital before they're discharged to that next level of care. Ditto stat for home health, it's about 11% increase. So, this is creating a significant challenge. Not good for our health system to be keeping these patients that much longer when they are ready to go home. And it creates, a real challenge for our value-based care populations. One more stat I'll share with industry trends that, I think maybe I've shared a couple slides that are, this is getting so hard, we have such a problem. I think there's some indication when we look at the most recent data, it could be getting a little bit better. So the last trend I'll share with you all is a trend of the average number of referrals that needed to be sent to place an inpatient stay to the next level of care. So this is SNF, home health, IRF, LTAC, hospice, the 5 post-acute care settings that are certified and shared on Medicare Care Compare. And what you'll see is we trend that, we'll see the average number of referrals. Used to be in 2019, you needed to send about 3.5 referrals to place a patient. Okay, we are now seeing that number closer to 6 or 7, but you'll see for the last 2 quarters, that number of referrals being sent per patient has dropped. I'm also trending the average hospital length of stay, and that used to be in about 6.5 days in January of 2019, and it was 7.4 days in 2023, but we're starting to see that improve. I'll also add that when we look at acceptance rate from referrals, we look at July 2019, 38% of referrals to post-acute care are accepted. That has decreased to only 33% in July of 2023, but it's a significant improvement from where we were of July of last year, where only 27% of referrals were being accepted. So I will say, looking at some of these industry trends, silver lining, we might see some relief in sight. Okay, now I just told you some of the trends that we've been seeing at a high level. Let me move to what I think is some of the practical advice from some of these industry trends. And I'm going to talk about that in the context of one of the levers in which we can pull to control costs and improve quality and value-based care, and that is in building a high-performing network of post-acute providers. This is something many of the WellSky CarePort solution clients have been doing successfully over the last 5 years or so. And, a very common lever pulled in value-based care. So let me share some of the things that haven't changed and some of the things that have. So one thing is, I think this continues to be a really powerful lever for value-based care organizations. The variance in quality in spend, particularly in the skilled nursing facility industry, continues to be really significant. 40% of your episode spend is going to happen in that post-acute care space. And one of the most recent stats I've seen that came from the National Bureau of Economic Research, they did a paper last summer where one of the stats that I thought was particularly revealing is they said if you compare a 10th percentile SNF, so like a SNF on the lower end of efficiency, to a 90th percentile SNF, so a SNF that is like very efficient in providing high quality care. You control for patients' clinical characteristics, you control for market characteristics. Same patient, that 90th percentile SNF can get that patient home safely a week sooner than the 10th percentile SNF. So as you can see, I mean, it's not overly complicated. If we can get our patients in value-based care to these higher quality post-acute providers, significant savings and quality will occur. Now, in the last year, we've had various health systems using our tools. We have one solution called Guide, which discharge planners use and put in front of patients when it's time to select their next level of care and the right post-acute provider that they want to go to. What I've done is I've aggregated what some of those stats look like for some of the health systems using our tool. And so you can see here, I got a sample of these are 12 health systems that are all using our Guide solution to inform patients of the best providers, their preferred provider network. Couple stats, the average health system has about 27 SNFs in their network versus the market that they've called out as high quality. Although I'll say all of our clients have very different approaches to how they do this and how big their preferred provider network will be and what they consider. But on average, it's about 27 SNFs. And as soon as they flag a SNF as, hey, this SNF is now a preferred provider, part of my network, I'm going to get my discharge planners in conjunction with our solution at Guide to educate the patient and their family that this is a high quality provider. We tracked the average number of placements that post-acute provider received from that health system before being part of the network and post being part of the network. And what you'll see here is so this first health system, a SNF that was just in their market on average, not a preferred provider, was getting about 12 placements a month. So you're still getting, patient choice. A patient will go where they choose, even if you're not part of the preferred provider list. They might get 12. As soon as they join the list and they're called out and the patient is educated, that number jumps to about 18.3 placements per month. And net, if you summarize this across our clients that are engaging in these activities, they can increase the volume of patients they get into their network by 188% as soon as they flag that patient as being part of their preferred provider network. So I think, this is sort of in the category of something that is old. Our clients have continuously been able to do this, but just showing the value, you really can, if you take the steps to inform your patient while maintaining patient choice, they will go to these higher quality PAC providers. I'll also add in the last year, one of the things we're always tracking is, what are the characteristics of a post-acute provider that gets put into one of these preferred provider networks. Of all the quality measures, there are probably hundreds of quality measures you could be tracking. And I think all of our clients probably have a different slate of quality measures that they are tracking. But what are the key to making it to a preferred provider? And we found that these are the 4 strongest predictors of entering into one of our clients' preferred provider networks. And I don't think this will surprise anybody. It's like a SNF's 5-star rating, their rehospitalization rate, the rate at which they successfully discharge to community, and the average number of days they're in a facility before they discharge back home safely. I think all of our clients, it at least would say that these 3, rehospitalization, discharge to community, average length of stay, is in like every scorecard, dashboard consideration for getting into for being part of a network. You know, I thought was interesting when we did this analysis. I've heard, you know, this a little bit anecdotal, but I've heard almost all of our clients say that they realize 5-star is a flawed measure of SNF quality for various reasons. You know, state surveyors are not getting out to see nursing homes. The data is old, is from claims. But I did think it's interesting that this is still a really important predictor of getting into a market. And it could just be that having a 5-star rating is correlated with doing other things that are high quality. So these things here, you know, these metrics to the right, this is the marginal value to every patient that gets into that preferred provider network, right? So what is the preferred provider network doing compared to the market at large? Patient gets into our client's PPN, they're going to a 1/2-star better facility. They're going to be re-hospitalized 2% less. They're going to get home safely 2% more, and they're going to spend 4 fewer days in the nursing home before they discharge back home. So significant savings, right? Both in terms of, you know, financially to the value-based care arrangement, as well as the patient getting home safer sooner. So I think that might be in the category too. I'm a little bit sharing some things that are probably like, okay, yeah, you know, we knew this. You've got to build a preferred provider network. These measures are probably things you're already tracking at your organizations. I will say one thing that I think is somewhat new that we've seen in the last maybe 2 years as it relates to the industry trends is it's getting harder to make these care transitions. And we've got a pain point from health systems where they can't discharge their patient out of the acute setting fast enough. There are some additional quality measures that I think that value-based care providers should be tracking. And one of those is sort of like a process measure acceptance rate. So if I send you a patient, how often do you take that patient? How often are you willing to care for that? You're willing and able to care for that patient. This first kind of got on our radar when I saw an article from Guardian Healthcare, a nursing home operator, where right at the midst of SNF having occupancy problems, you know, they were able to double their skilled short stay population referrals to their providers. And they did that not through advertising the classic quality measures, low readmissions, low length of stay, but through advertising, hey, if you're having discharge, hospital length of stay issues, I always accept your patients. Like I'm always equipped to care for your patients when you need them to go someplace. And they greatly, through that strategy, they were able to increase their volume. So what we did to sort of like vet that, you know, this anecdotal evidence is we did an analysis where we stratified, we looked at markets where there's like many nursing homes, like, you know, competing for referrals. And we stratified them from best to worst, best being relative to my peers in the market. I'm always, you know, willing and able to take your patient when they're referred to me. Worst being, I'm constantly rejecting your patients. I really only will take a subset of who you're referring. And then we looked at the average hospital length of stay to those post-acute providers. And like what we found was pretty impressive. If you send your patient to a nursing home that is always saying yes to your referrals, their average length of stay was 9.4 days. If you're sending that referral to a nursing home where they're constantly saying no, that average length of stay is 11.7 days. So, you know, a 2-day delta in hospital length of stay. So, I mean, one other thing to consider outside of the classic quality measures is like, am I getting the patient discharged in a timely manner? And are there other measures you should be tracking for that? And then I'll share one more. This is something that the health systems of the CarePort Solutions are tracking today, various process measures for these referrals. So like, you know, I won't spend a lot of time on this, but like, where are the majority of my patients being referred, right? You're going to want to make sure that your patients are being referred to your preferred providers, right? Like it might be a problem if you tracking this data and the bulk of your referrals are going to a provider that's not who you have not deemed preferred. You might also look at acceptance rates, but not just all acceptance rates by payers, because we'll see one of the greatest predictors of whether or not a post-acute provider will accept a patient is their payer status, right? And so unfortunately, a Medicaid patient is about twice as likely to be rejected from a post-acute provider as like a classic Medicare fee-for-service patient. And so, the Oak Skilled Nursing Home here, they might actually be someone you want to consider entering into your preferred provider network, even if their classic quality measures are not the best in your market, because they are willing and able to take your Medicaid patients like, 4 times greater than your market benchmark. And then one last thing you want to track too is like timeliness of communication. We've also correlated the time at which a post-acute provider communicates with a discharge planner is correlated with how quickly that patient gets out of the hospital. So just as we look at some of the industry trends that are showing care transitions continue to be difficult, you might want to consider some of these additional metrics when building out that preferred provider network. So with that said, that was a bunch of data. Devin, why don't you tell people how it's actually working and some of the stuff you've put in action at VNS?
Yep, thanks a lot, Tom. And as you can see, wealth of information that WellSky is able to provide in this space, and we leverage it in a number of different ways, and we're going to share a bit of that this afternoon. So for those of you who aren't familiar with VNS Health, we're the second largest not-for-profit home health agency in the country. As you can see, we have a number of different divisions. I'll start from the top left. We have our home care and personal care division. Our home care division and personal care, we started roughly 130 years ago in New York State. We're only in New York State, the downstate markets, 5 boroughs, Westchester and Long Island. Pivoting over to the right, we have hospice. Also, our hospice is the largest in New York State as well. And pivoting down the right, we have our health plans. And so we actually did start a number of health plans roughly 25 years ago. And those health plans we really focus on, especially the Medicaid long-term care space. And then we branched into the duals, the dual Medicaid and Medicare, again, that had chronic needs or high needs population. And we've also launched into a number of different straight MA products as well. Then pivoting down the right, we have our professional solutions. That's really service that we're able to provide to other health plans, like health plan benefit management. And a perfect example of that is hospice VBID. So our health plan, we actually worked with our health plan. We're actually one of the first 6 to participate in the hospice VBID model 3 years ago. And now we've learned a lot and developed a lot of algorithms and things to support that population and built care programs that start on the provider side. Now we've really figured out how payer and provider can work together to make this a really successful model. We now are able to support other health plans in launching into VBID or into doing kind of like a pseudo VBID. So not even straight VBID, but kind of working together on how things like palliative care and advanced illness management, the benefits that those have for, again, payer and provider. Going back over to the left-hand side, we have a behavioral health division. We have roughly 500 folks out in the community doing home and community-based services, crisis intervention. We also have an Article 31 clinic. And they also have a number of solutions that they provide to health plans that are more like longitudinal and episodic solutions, so not your classic visit-based. And then on the bottom left, we have our care management organization that we're going to focus on today as they work with basically all the different provider divisions here. They're kind of the hub that really ties them all together into, again, episodic and longitudinal solutions to partner with the health plans to unlock total cost of care. All right. And so for VNS Health, as I was saying, because we do have this payer side and provider side, our payer side actually accounts for over 2/3 of our revenue now. But a lot of that is in the success of the payer is because they're able to leverage the provider side. So this long history of 130 years of being boots on the ground in New York City, provider really understands the population here, as you saw, from all aspects, from medical, behavioral, et cetera. And so there's this space of overlap between payer and provider, and that's where value-based works out really well, right? And so some of the time it can be formally or informally delegated. Some of the health plan services, especially the care management services, to be done by a provider. An example is when we do longitudinal, these are some of the sickest folks, right? So 6+ chronic conditions. Payers aren't set up to have the level of care management services to really help those folks that really need it the most, right? Whereas on the provider side, that's where our area of expertise is. And so by focusing the provider care management teams, focusing on that population, having much lower caseloads and all these other tools that a payer does not have, that's how we're able to really unlock value when it comes to total cost of care opportunities that then we're able to do shared savings. Next slide, please. And so in the care management organization I was talking about, these are some of the big opportunities we use to work with health plans. And so I'll start on the bottom left there where it says transitional. So transitional care, this is episodic, right? And so we're doing case rate. Case rate's bundling our care management organization with our home health organization. So when you have someone coming in on what in New York State, what we call our CHA, our Certified Home Health Agency, they're going to come on for, on average, generally 30 days. But we'll actually do contracts with the payer. We'll actually be at risk for either 60 or 90 days for rehospitalizations and sometimes other metrics as well. And when we're doing that, we're able to then take on, we're doing episodic. So now we're also accountable for how many visits are being rendered during that time. But also we're able to leverage all these different technologies to decrease those rehospitalization rates or hospitalization rates if it's a community referral. And so that is bundling, again, the care management organization, which is roughly a 55-person interdisciplinary team with everything from health coaches, nutritionists, LCSWs, RNs, dietitians, pharmacists, all these different disciplines. They're able to really address the population, have a more holistic approach. So it's not just, exactly what the discharge diagnosis was and treating that exact diagnosis. They're actually working very holistically with the member to try to decrease potentially avoidable hospitalizations. So in case rate, it's the care management organization bundled with the CHA, the Certified Home Health Agency. Post-acute is actually just just the care management organization. And so there's still an initial RN assessment that's done, and that's kind of really driving the care plan. But then there are no ongoing visits during that time, during the 60 or 90-day period. It's really just managed by the care management organization. Those are folks who don't qualify for certified home health. So that's transitional, that's episodic, and again, has a value-based component to it because the health plans always want to know what are they getting out of it and what is the ROI. And so it's a really good opportunity for us to true up and make sure that we're delivering on things like HEDIS and STARS for quality, and again, decreasing total cost of care. Now going over to the middle, sorry, still on that slide, sorry. In the middle, we have palliative care and advanced illness management. These are two of the key clinical and provider aspects of that hospice VBID model that we were talking about. So I know for providers, especially hospice providers, there's been a lot of concern of how this would play out with the managed care, it being carved in for managed care. But when we're doing palliative care and advanced illness management, this is actually a new opportunity for us. So we've actually had to build a full palliative care management program where we're actually leveraging MPs versus the RNs that are really leading the longitudinal program. And so again, gives us more time to work with the member and working with the health plan. And so we work with the health plan on when it's time to transition to palliative, then they're on the palliative care program for roughly 6 months. And then advanced illness management is when's the appropriate time to transition from palliative care over to hospice. And for us, being in New York, number 50 in the country for having the shortest hospice average length of stay, this has made a drastic difference in the hospice average length of stay. So it's all about appropriate transitions, and managed care being involved, that's their job, is to manage care. And so they understand that message. So when they're at risk for it, when they're actually managing it through VBID, that's actually opened up opportunities for us. And then on the right, we have longitudinal. That's really one of our biggest areas of growth and areas of focus. And that is managing members up until that palliative care trajectory. So these are folks, again, 6+ chronic conditions. They're not going to graduate off of this, unfortunately, right? Their health is only going to worsen. And so it's how do we manage them best to keep them comfortable and stable in their home. Next slide. So tracking regional trends. So pivoting back over to some of the data that CarePort provides us. And so when you're looking at the bottom there, you're seeing the hospitalizations. These are actually referrals that are coming to our organization. And so you're seeing the trend is that it's actually increasing over time, right? And for us, good news, you're getting more referrals. It means your business should be growing. Unfortunately, when you're looking at the line on the top, our conversion rate is going down. And it's not just going down because we're getting more referrals. It's also because, as Tom was talking about earlier, it's also capacity. We just don't have the same staffing that we had 5 years ago. And so there's kind of like this double crunch. And so that is actually, unfortunately, it's a problem, but we also look at it as an opportunity of how can we then change some of our care models. As you saw in that last slide, our care models are, very different. We've put a lot of work into them. And that's what this does is, how should we be pivoting? And one example is in the industry, there has been a trend towards things like SNF at home and hospital at home. Those are very intensive, right? Some of them require like daily RN. And imagine if we can't even keep up with our home health referrals where you're doing, let's say 10, 12, 15 visits in a 6-day period. How is it possible then to have the staff to be able to do some of those really high need programs? And we've just found that for us, it just hasn't been an area that we can focus on. Instead, we're pivoting to look at some of the lower need. So some of those cases that, again, a lot of folks just aren't getting any care at all. And again, we leverage CarePort to work on in our region, what is happening with these folks and what is the profile of the members or patients who aren't getting any services at all? And what is the opportunity to unlock there? Is there an ROI by working with the health plans? Next slide, please. And so this leads into our program development. And so the area of opportunity we've really been looking on, again, is these lower need members. And we actually did a pilot with a local health plan on 1,500 members. And for folks who did not qualify for certified home health, but the health plan had flagged as, kind of those revolving door members that had a high hospitalization rate, we're actually able to decrease the rehospitalization rate by 75%. So again, in New York City, where you're talking about your average hospitalization being $25,000, we're talking about unlocking millions and millions of dollars in opportunity. And for us, that's enabled us to kind of pivot away from some of that visit-based care into taking on risk and working with health plans on managing populations to, again, generate savings and then sharing those savings. Next slide. And again, pivoting back over to CarePort data. So now you dive into the value-based space. How are you managing it, right? And what are some of the things that you have to be mindful of? And look at this slide. One thing you notice is there's a lot of peaks and valleys, right? And so this is looking at folks who are discharged, right, from inpatient facilities. And even when you dive in, we look for things like seasonality trends. Like the simplest example is, it's springtime in New York City. It's, April. Cherry blossoms, all the pollen hits, COPD, and all of a sudden folks are rehospitalizing or are hospitalizing. So not even rehospitalizations, but initial hospitalizations, right? And that's what we're looking at in these trends. And so that then allows our care management teams to focus on the following year. When is that pollen season going to hit? In advance of that, do folks have their inhalers? Do they have their allergy medications? Are taking those allergy medications and inhalers in advance before it actually hits, before the problem starts? How can we get ahead of that and ahead of those trends? And so these are some of the things that we really dive into to, again, help our performance with the population. Another thing is looking into this with the seasonality. It also helps us out for my team, the contracting team. These are things that we think about when we're starting new contracts. Because let's say we're doing a new value-based contract, and let's say hospitalizations tend to be lower in the first quarter and higher in the second quarter due to this, spike in pollen that happens in April. One thing is, you wouldn't want to start a contract necessarily then right at the beginning of the second quarter, because it may look like your first quarter performance is actually poor versus what your baseline was for the prior year. So these are all things that we take into consideration as we're doing value-based contracting as well. So again, this type of data from CarePort really helps us out. Number one, for program design. Number two, for informing the clinical teams of trends and things they should be looking into. And number three, for the contracting team. And the next slide here, we're actually going to show you the contracting team, how we leverage some of this data even further. And so this slide here is an actual slide that we share with the health plans that we have value-based contracts with to show them what the trends are. So this is the most informative slide that we have. And so the bars that you're seeing on the bottom, those are when folks are coming in, we're actually putting them through our proprietary predictive algorithm, and it's determining if those members are low, rising, or high need of care and of rehospitalizing. And so that is informing us of how intensive the services are that we need to provide to those members. It also is showing the health plan what the trends are within their population. So I think health plans tend to feel their population's fairly static, but showing them quarter by quarter, as you can see, the high risk in that Q2 2022 versus the Q1 2023, it's gone up significantly. And you can see it goes up and down, right? This is also important because when you're looking at those lines, the bottom line there, the black line, that one is the 30-day. Those are actual hospitalization rates that we're getting from CarePort, right? And then the top line is the 60-day hospitalization rate. So again, depending on the contract, it could be a 30, 60, or 90-day review period for a value-based. And so when we're sharing this slide, we're giving the health plan a look into their crystal ball because they're probably leveraging claims data. Their claims data, of course, they're going to need a 6 months claims run out. Their files are probably going to be anywhere from 18 to 6 months old, right? Versus for this is real time. We're showing them the prior quarter. So we're showing them what they're going to see in the future. And so without having this CarePort data and then being able to layer on the risk of hospitalization, it tends to look as if your hospitalization rates are kind of up and down, as if you're not really controlling the population. But then when you layer in the risk of hospitalization, now you can see the story. You can see that the line is generally going up as the high risk is going up, and then coming down as the high risk is coming down. Now, there's another key aspect to this CarePort data, and that is this is actual hospitalizations. So again, I came from the health plan side. I was with one of the large national payers for a number of years before I came here, and I was doing value-based contracting there. And really all we leveraged, like our source of truth on the payer side, is the claims data. But coming from the provider side, as we all know, or even on the payer side, not necessarily everything you submit gets authorized. So there's a gap there, right? Then not everything that's authorized does the health plan actually pay. So when the health plan is looking at paid claims, because that's what they're thinking is their source of total cost of care, if they didn't pay for it, it didn't exist to them. But there are critical incidences that happen with these patients that aren't being captured there, right? And so that's the real opportunity for providers. We drill in using this CarePort data to set up our clinical teams. They're looking into every single hospitalization that occurred and how that can be prevented, because there will be a trend. If you don't stop that trend, it is going to be one that hits claims that's then going to drive up the total cost of care. So again, it's getting ahead of that by addressing every hospitalization, and that's what CarePorts gives us, is a really full picture. And then another aspect of that picture is that health plans also, they don't, let's say a health plan, they're going to be more creative, they're going to go upstream and they're going to use their auth data, right? Because that is real time, as is CarePort. The thing is, their auth data is missing the ED utilization and the OBS beds. And the ED and the OBS, those are also critical pieces that our team drills in on, and not only works with we also work with the facilities to try to drive down the average length of stay. And so on our programs, the average length of stay is roughly 43% shorter, because we're getting those feeds from CarePort, we're finding out what facility they're in, we're engaging with the discharge planners at that facility and letting them know that there's a program that will keep them comfortable and stable in their home once they're released. Next slide, please. So what is the impact? And so as you can see here, we have Health Plan A, which is, this is one of those case rate programs that's bundling our care management organization with our certified home health agency. As you can see on the left in the Medicare space, we've done pretty well, averaging roughly 14% decrease in hospitalizations. For us, that amounts to a couple $1 million a year in bonuses, so very significant revenue-wise for our organization. On the right-hand side, as you can see with Medicaid, we haven't been as consistent. Luckily, though, we've been able to drill down and, again, leveraging a lot of CarePort data and understand the populations better to really understand where the opportunity is to unlock. So we were actually launching some stuff that for 2023 and 24, very excited to see how our outcomes improve working with the Medicaid population. And then Health Plan B at the bottom. This is also an interesting one, and especially from a contracting perspective as well. As you see, this is blended Medicare and Medicaid. In 2020, 18% reduction, amazing. 2021, 25% reduction. Now we're talking real numbers, right? So we're talking about another couple $1 million in value-based bonuses there. 22, it went back to 11. And we drilled in this health plan, their Medicare population shrank significantly. And as you can see, historically, that's where real success has been. So now it's a lot more Medicaid, and that's actually what's changing that outcome, because we didn't break it apart like we did in Health Plan A. So again, all this type of data also helps us from a contracting perspective to understand different ways we can set up the contract for success for our teams. Next slide. So now we're going to drill into just some of the screens of exactly how our care management teams using the CarePort data. And this is for the longitudinal program. So longitudinal folks are on there for roughly 3 to 5 years. So our care managers get to work very closely with them to manage their care over time. And so as you can see here, they can search for utilization. And in the utilization, they're going to put in, as you can see, all the information here. And you're looking for things like home health or hospice, hospital, post-acute, but all the utilization trends to really figure out how is this member utilizing the care continuum in our region. Next slide. And so now you're starting to see the patient list, right? And so this is what's coming out. And as you can see, you're seeing what facilities, some of the time the facilities will even have documents in here, documentation that you can actually go in or you can request documentation, but also it allows you to engage with those facilities, especially if it is, as you can see, it's one system that they're using here. We can engage with that system to find out what's going on and what we can do to interact with them and potentially prevent some of these cycles that are going on that are driving up the cost of care for that member. Next slide. And so, as you can see, for our longitudinal program, being able to leverage this CarePort data is absolutely critical, right? So this is what our care teams are really depending on in finding those members, closing gaps of care, trying to break some of those cycles that are driving up the total cost of care for the population. Next slide. And lastly here, we have some of the reporting, right? And so this is looking more high level. It's also, you have care managers are assigned to each, they have their batch of members that are in their queue. But this is actually for leadership to be able to look down and just look high level, who are the high utilizers, right? So someone maybe at the director or manager level, they're looking for high utilizers and they're working with their team to say, look, there's, as it says here, there's whoever it is, John or Mary, they're having really high utilization. How can we work with them to kind of break those cycles? Next. All right, Tom, back to you.
Today, you guys have heard, some of the industry trends we've shared, some of the new measures you can consider for building a PPN, and some of the ways you can use technology to help your care management teams and develop new programs to better fit your population. I think with that, we're going to pass it over. Garrett, are you going to help us facilitate the Q&A?
Indeed, I am. Indeed.
Okay,
thank you both so much, first of all, for a great presentation. We do have some questions. We don't have a lot of time, but we're going to get to as many as we can. If you do have a question that you'd like to ask either of our speakers, go ahead and ask it now, and we're going to get to as many of them as we possibly can. But if you don't, if we don't get to your question, don't worry. Someone will reach out afterward and send you an email about it. Okay, well, real quickly. First question is this: how could other providers, home health or SNFs that don't have the same level of volume that VNS might use these solutions or CarePort solutions to improve relationships with the payers?
Yeah, I think I think some of the stuff we were going through, actually, especially some of the screenshots, we can at least, you can see some utilization and track where those members are going. I think it really helps to build some of those relationships, because some of those providers upstream, they may have really strong relationships with the payers. And so for us, we actually do work on that. We do work on our hospital relationships as well. As much as we meet with health plans on a quarterly basis, we also meet with our major referral sources on a quarterly basis as well, where we can, again, track some of these trends, how we can put down by payer, and especially it could be a referral source that they're working on a contract with a payer. We can show them that when we tie together with them, the value that we're able to bring to the table.
Wonderful. Next question, really quickly, and unfortunately we're going to have to wrap it up here. But how could other PAC providers use CarePort to expand their value-based programs?
Devin, I'll take that, and I think Yeah, I guess it's a similar response to what you just shared, Devin. I mean, even if you're a smaller post-acute provider, not at the same scale or sophistication as VNS, you know, as far as using our solutions, I think maybe the lowest, I wouldn't say lowest bar, but one of the first things you can do as a post-acute provider is understand the patient populations that are being referred to you. Just profiling, just where are they coming from? What do they look like? Understand that first, and then maybe you can get into more sophisticated operationally. Now, what do we do? What business action do we take to better support that population? So I would just say, understand, profile those patients, know where they come from. Step one. And then, you know, maybe I'll add step two, so I'm thinking about it some more, right? Understand the measures that matter to your referral partners. Like, what is it that's, like we talked about that PPN network, you are going to increase your volume of patients if you can get in one of those networks. Know from your referral partner what matters most to them and be tracking those things as well.
Now, not a lot of time, but yeah, two things for us, all the value-based contracts. One is timely initiation of care, right? How quickly you can take on that member like Tom was talking about and then get that care out there. Number two is preventing rehospitalizations, which again, we leverage as well. So again, the two critical things, CarePro provides us both.
Great. Well, unfortunately, we are out of time, but I wanted to thank you both so much again for the presentation. This was great. I know I learned a lot. I hope you all did as well. As we close out, I'd like to welcome you and encourage you all to check out the WellSky exhibit booth, the virtual exhibit booth they have on bbcexhibithall.com. There will be a link to it in the slides that we'll provide, but head over there. There's a lot of great resources. You can read up on them, what they're doing, and a lot of neat things that they're into, and really educate yourself on their services. And of course, you'll be able to reach out through there as well. Also on BBC Exhibit Hall in the library is where we're going to archive today's webinar. So you'll be able to access it there as well. However, we are going to send you a link where you can get that webinar as well as the slides from today's session. And then finally, if you would like to reach out directly to the WellSky team or to either of our speakers, their information is here on the slide. And feel free to do that. Or if you'd like to reach out to me, I'm happy to facilitate an introduction for you if that's easier. But look forward to seeing you all on a future webinar. Thank you all so much for joining us today. Hope you have a very happy Halloween, and we'll see you on the next one. Thanks, guys. Bye-bye.
Thank you.